Understanding comorbidities and multiple diagnoses in ABA can be challenging, especially if you don't have a multidisciplinary team. When an individual has more than one diagnosis, it can impact how we approach assessment, treatment, and support. So, how can we best support individuals with complex needs?
Hi, I'm Shira.
And I'm Shayna.
We're behavior analysts who create weekly content about how to teach kids with autism so that they make real progress. And we create shareable resources to make your job just a little easier. Today's topic is all about understanding comorbidities and multiple diagnoses in ABA. And if you want more videos like this, make sure to subscribe and hit the notification bell to stay updated on new video releases.
So I was recently at the physiotherapist because one of my goals is to start running again. And I did. I started running and my hip hurt. So I had to go to the physio for some help. And she was giving me some exercises, but it didn't help with the running because I also have a toe issue. And she didn't know that at the time. So once she knew that, she was able to help me more and give me exercises not only for my hip, but also for my toe. I guess the question is, how does this relate to kids with autism and ABA?
Well, that's a comorbidity. It's two things happening at the same time that are really affecting each other. And that is what we're talking about when we say that two diagnoses can be comorbid. Really, they are occurring together. And a lot of the learners that we work with have often multiple diagnoses, and a lot of these diagnoses actually go together. So ASD is often comorbid or comes together with a diagnosis of ADHD. It doesn't mean that they have different criteria to qualify for each one of those diagnoses, but they do often overlap. And actually, some of their presentations look similar. Similarly, with anxiety and ADHD are often comorbid. And it is important to know because while we're not treating a label, we're not treating a diagnosis, we are treating the behaviors. It is helpful to know what some of the physiological components of the diagnoses are, or what some of the presentations are in when we're treating them together.
There's often multiple challenges that come with that if you only treat one and not the other. So making sure that you look at that. I'm also recognizing that there's no one size fits all approach. It's not about, okay, well, I have my curriculum and I'm just going to check off boxes and here's what we're going to do. We really do need to make sure that we're individualizing our approaches to each individual. And some of that comes with working with a multidisciplinary team. If you don't have other professionals involved, it might be time to look for those other professionals. The very first thing I would do is go to a medical doctor and make sure that there is nothing happening medically, and then seek out the necessary professionals for sure.
And while we say, we want to know what the labels are, we're not actually treating that label, right? So we're still looking at what the behaviors are that are underlying, and then making that individualized intervention. What we want to avoid is this like circular reasoning where we end the conversation at, well, they have ADHD, so that's the reason that they're not focusing, or that's the reason that they're not able to attend. And what we want to do is kind of avoid that, where it might be contributing to why they are very active or why they have trouble focusing. We still have to look at the environment and think of, yes, well, this is a component of the big picture and the whole picture, but what are, the behaviors that we want to see or that we are seeing, and how do the environment and the behavior still affect each other? And that's the part that we don't want to end the conversation at, well, there's a diagnosis, and that's the end of the conversation. We say, well, yes, there is a diagnosis, but let's continue to investigate, when is it happening that they are most inattentive? Or is it when they're bored? Or when are they most rigid? Is it when they're trying something new? And those are things that are real triggers in the environment that, yes, do bring out some sort of, physiological reaction. But if you can, track it back to something in the environment, we have a lot to work with.
Absolutely. And if you can assess how those different conditions interact with each other, that's what behavioral analysis is all about. It's not about, well, they have ADHD, so that's my excuse and that's why we're not doing this. We really do need to say, okay, well, how can we work within these extraneous variables? Other things we need to consider are cognitive functioning, emotional regulation strategies, environmental modifications. Like I've already mentioned, collaboration with other professionals. Sometimes we talk about this can't do versus won't do approach. And, sometimes with individuals, it's not that they won't do something, it's they actually don't have the skill to do something and they're acting out because they don't have that skill. And this is what they've learned how to do and how to navigate their environment. So looking at that as well.
Yeah, we talk a lot about this when I'm working with preschoolers, so kids who are like 5 and under, and it always becomes a behavioral challenge that, they can't sit at circle time. And circle time might be 20 or 30 minutes, and we can exhaust all, and they've tried all the reinforcement systems and they've tried all the motivation, and it's getting more and more of a behavioral challenge. From their perspective, because they're just not, they're not listening. They're not attending circle time. And then, you look more into it, and then there may be an ADHD diagnosis, there may not be, but it might actually be a can't do. And it might be that their body just isn't ready, and hasn't have the skills to actually be able to sit for 20 to 30 minutes at a time. And that's where we'll put things in that are non-contingent. It's separate from reinforcement, and we'll do things like movement breaks or breaking up circle time. So it's little 10-minute chunks at a time, and they can move in between. It's not something they have to earn. Remember, this is separate from a won't do, from a motivation. This might just be something that they are getting access to because of the way that their body is reacting to the environment in a certain way. And they don't have to earn it. And then once they, that it is something that they can do and it's within their repertoire, that's when you can look at things like reinforcement and motivation and all of those things.
We have a can't do versus won't do cheat sheet. So we'll definitely put that with this video as well. Another big thing when we're doing behavioral analysis, especially with comorbidities, is the ability to be flexible. And, it's not about teaching our kids to be flexible. It is, obviously, we teach our kids to be flexible, but we ourselves need to be flexible because sometimes one intervention may not work, or, you're trying to teach in one particular way and that doesn't work. We need to be able to pivot, and we need to recognize when something isn't working, aka data analysis, and pivot when we need to pivot.
And then thinking about things like a trauma-informed and compassionate approach. Some of these things we may not know the background. A child could have developed anxiety because of something that may have happened previously, even if it was something major or something, not as major, but to them it was somewhat traumatic. We want to keep that in mind. Also, we work with a lot of students who have with comorbidities. One of those is a medical issue. And sometimes kids with medical challenges have gone through so many procedures and so much trauma that comes around with having to be in hospitals and having to do testing, and that on top of the ASD. And we really have to be mindful of that when we're incorporating, when we're thinking of, ways to work on that we're incorporating this compassion and trauma assumed care and not, doing anything that might make them feel uncomfortable.
For sure. And looking at setting events with that as well. So, we talk, some people talk about it as barriers when you're looking at trauma informed, but it's also setting events, right? So, if someone has ADHD and is on medication for it, some of those side effects of the medication are that they don't sleep properly or that they don't eat properly and that kind of thing. And if you're not sleeping properly and you're not eating properly, that can also lead to an increase in challenging behavior. So take a look at some of those setting events as well.
And then thinking about functional skills, if you're working with students with comorbidities, sometimes some of those comorbidities may actually, like it is a can't do and may get in the way of learning specific skills. If they have a diagnosis that affects their fine motor control. And as much as we try, they may not tie their shoes, So then thinking about, well, what's going to be functional instead of me focusing on shoe tying for a long time, let's pivot to something like, making themselves a meal or something that they could do that is within the skills that they'll be able to develop, taking into consideration all of the diagnoses that they're dealing with.
And that doesn't mean giving up on things. It just means, listen, like it's not necessarily functional for somebody to tie their shoes anymore. There's shoes out there that are slip-ons that look really great. So you don't necessarily need to focus in on that. Another really big thing is to make sure that, your reinforcement systems or other strategies are really appropriate for all diagnoses involved. So it's not a matter of saying, okay, you get good job, you get this, here's a piece of candy. That's not appropriate for lots of different reasons. So making sure that you tweak that reinforcement system.
And also collaborate, like seek help from other professionals, work with medical professionals, OTs, PTs, SLPs, social workers, whoever else you can to help support, the big picture of this individual.
We already talked about knowing the difference between can't do versus won't do. So I think really the big take home message here is that when you can understand the comorbidities, you can really better support the individuals we work with. For more information on comorbidities and multiple diagnoses in ABA, click the link in and around this video or in the description to claim your free can't do versus won't do visual. And we also encourage you to subscribe to the channel so that you don't miss any future videos, and leave a like and comment below if you have further questions.